Hello, I'm Lalani Carlton Jones. I'm a consultant neuroradiologist working at Guy's and St Thomas's and King's College Hospitals in London in the United Kingdom. And I'm going to be talking about spontaneous intracranial hypotension and spinal CSF leaks, a debilitating condition and one in which the radiologist plays a critical role. I hope you enjoy this talk.
Spontaneous intracranial hypotension, also known simply as SIH, is the result of a spinal CSF leak. It is a condition which causes considerable suffering, impacting patients' lives in a multitude of ways, including many having symptoms so severe they must stop work, lie down for most parts of the day, and many having feelings of depression and hopelessness. But importantly, it is a remediable cause of headache and other symptoms. Many patients wait a long time to reach diagnosis. It's under-recognized in the medical community, and even when it is recognized, there's non-uniformity to the approaches in managing these patients. So in this talk, we're going to look at the clinical and imaging presentation of SIH, identify what the causes of spinal leaks are that cause it, and how to find them. And that can often be a challenge in itself, as some of you watching may be aware, if you have ever tried to investigate these patients. Now, advances in the fields of investigating SIH have developed significantly over the last 10 years, and that's enabled appropriate management to reach more patients than before. But we still have some way to go, and failure to use the correct imaging approach can lead to disappointing results and a sense of diagnostic nihilism. We will look at how, when successful, you as radiologists play a critical role in the successful diagnosis, investigation and management options for these patients. And through this talk, you'll gain tips to undertake that role. So let's start with a question centered around a case. Have a look at these images. This was a 47-year-old woman who presented with a 4-month history of neck pain, new onset sleepiness and confusion. Interestingly, there was no history of a headache. But over the next few weeks, she underwent a rapid clinical deterioration, with a rapidly progressive dementia progressing to a semi-comatose state as an inpatient. So faced with that clinical scenario and these images, what would you do next? Now, this is a question for which there may not be a uniform correct answer, but by the end of this talk, I'm hoping you will be more able to clearly outline a solution to. We'll come back to this at the end, but keep this at the back of your mind. So let's have a look at what we're going to cover. We're going to look at what is SIH and what causes it, how we then go on to make the imaging diagnosis of SIH, and how we localize what's causing it. And finally, we'll look at the management options for these patients with a focus on the radiologist's role in management. So simply put, SIH results from a leakage of CSF in the spine. And in this context, we're discussing spontaneous spinal CSF leaks, distinct from trauma or, say, iatrogenic causes such as following a lumbar puncture or, say, an inadvertent dural puncture during an epidural. Now, there are several etiologies which underlie spontaneous leaks, and it's important to understand the pathology in order to be able to find them. And these can be divided into several broad groupings of leaks: the dural tears, lateral leaks, and CSF venous fistulas. Let's have a look at each of these in turn. So firstly, we have the dural tear. Now, these most frequently result from a discogenic or bony spur which pierces and incises the dura, allowing escape and seepage of intrathecal subarachnoid CSF into the epidural space, and that will result in a spinal longitudinal epidural collection. We can shorten that to SLEC. Now, because most of these little discal spurs occur anteriorly within the vertebral canal, they will therefore mostly pierce the ventral dura and therefore result in a ventral SLEC. Now, lateral leaks can be from several causes. Firstly, they can result from a lateral dural tear similar to the ventral dural tear, resulting from a sharp spicule piercing the dura, or say a nerve root sleeve tear, which can be spontaneous or post-traumatic, and both of those usually result in fast leakage of CSF, in which case we expect to see epidural fluid, which may be circumferential or loculated more on one side. And we also have this entity known as the leaking diverticulum. Now, this is not a real diverticulum, it's actually a pseudo-meningocele, and it's a fragile outpouching of arachnoid mater at the site of a dural dehiscence, and you get seepage of CSF at the margins of that dehiscence. Now, these may result in fast leakage of CSF, in which case you expect to see a SLEC, or they may leak slowly, in which case you may not see any extradural CSF. Now, these are most commonly found at the axilla of a nerve root, and they may have a broad base with it. You can sometimes see meningeal diverticula on MRI studies, and they can be multiple, particularly in patients with underlying connective tissue disorders, but it's pretty difficult to predict from MRI studies which is the one that's leaking. It's not always the largest. And these can be distinguished from perineural cysts, which are common incidental findings, which are in continuity with the nerve root sleeve itself. Remember, these are actually fragile outpouchings of arachnoid mater through that fragile dura, so they're actually occurring at a site of a dural dehiscence. And then we have this entity which has gained more recognition in the last 5 years, the CSF venous fistula. Now, this is an abnormal connection between the venous system and intrathecal CSF, and these are associated with a diverticulum in the vast majority of cases. And this is where intrathecal CSF is being drained into an abnormal meshwork of venous vessels, and this is being drained away either via a segmental paraspinal draining vein or into the venous epidural network. Now, these are mostly found within the thoracic spine, and they're more common on the right side. The reason for that is not clear, but it may be due to the fact that many of these will eventually drain into the azygos system, and the azygos system runs on the right side. Now, there's a common misconception that skull-based CSF leaks can cause SIH, but there's no evidence that that is the case from large volume data sets. So in fact, if you have a patient with a skull-based leak that has clinical and imaging signs of SIH, make sure you're not missing the spinal leak as well. Now, typically we associate SIH with an orthostatic headache, so a headache that's worse on standing, the typical second half of the day headache. But actually, the clinical presentation can be much more varied than that, and that can also confuse the clinical picture to uninformed clinicians. And that orthostatic nature of the headache can lose that quality over time. And other symptoms are incredibly common and include, for example, auditory symptoms such as muffled hearing, tinnitus, visual symptoms, and back and neck pain are also common, as are cognitive complaints. So patients often describe having a brain fog. And in extreme cases, there can be a rapidly progressive dementia and coma. Whilst rare, it's an important one to remember because it can be fatal. Now, part of the International Classification of Headache Disorders, 3rd edition, uses some key diagnostic criteria to suggest how we make the diagnosis of headache caused by SIH, and the emphasis is placed on these 3 findings. But actually, studies have shown that only 30% of patients with a proven leak actually have a low CSF pressure at lumbar puncture. So that by itself is not a great diagnostic indicator. And that then places greater emphasis on the role of imaging, and therefore the radiologist, in making the diagnosis, which means showing evidence of SIH on brain imaging or showing that there's a leakage of CSF in the spine, either via spine MRI and or myelography. So we begin by making the diagnosis of SIH, which is mainly by brain MRI. Let's begin by looking at a typical case. So I find the midline sagittal T1 an incredibly useful sequence because it shows a number of the findings of SIH. The first is that of brain sag. So this is due to loss of the CSF volume supporting the brain. And what we can see here is that the superior profile of the midbrain appears pretty indistinct. It's been flattened and squashed downwards. The floor of the third ventricle has been pulled down. The mammillary body is drooping closer towards the pons, and generally you get a brainstem anatomical distortion. The pons appears flattened in its ventral surface. There's also evidence of cerebellar tonsillar descent, so evidence of brain sag. Another feature in a CSF low volume state is that we get a compensatory expansion of the blood volume compartments, and we can see that manifest in a number of ways. The first is of a venous sinus distension. Now you can see this at a number of points. I like to look at the midpoint of the dominant transverse sinus. So when we look here, what we can see is that the inferior border is downwardly convex, whereas it should normally be flat or even upwardly concave. But you can also see this compensatory blood volume expansion manifest as venous hyperemia. And we can see that again on this midline sagittal T1 when we look at the pituitary gland. So you get a pituitary hyperemia as a result of that venous hyperemia. And here you can see the pituitary gland looks enlarged with a superior convexity to its superior surface. But some of the other sequences are also useful. When we look at this T2 axial, what we can see here is further evidence of brain sag. When we look at the interpeduncular cistern, it looks squashed. Normally, you should be able to see evidence of the interpeduncular CSF. We also see here evidence of bilateral subdural collections. It's slightly larger on the right, and these appear like their sort of CSF signal intensity volume. It's more of mixed signal intensity on the right-hand side. And actually, there's also a shallow film-like collection on the left-hand side. When we look here, you can see the gyri just look minimally flattened, mild sulcal effacement on the left side. And those subdural collections can have a range of appearances. When we look at the FLAIR imaging, you can see that they're hyperintense. And then on the T1 imaging, you can see that there's a hemorrhagic component to that subdural collection. Now, one of the most useful sequences is to give contrast, and we're looking for smooth, diffuse, dural thickening and enhancement. And here in this case, you can see it's overlying both cerebral hemispheres. It extends into the posterior fossa, and all the way through, it appears smooth, contiguous, diffuse. Here you can see it extending into the internal auditory canals along the clivus, and there's nothing else which can cause that really. Here again on the coronals, you can see supra and infratentorial dural thickening and enhancement. Infiltrative or neoplastic causes would be expected to be more irregular, patchy, discontiguous. And that finding is due to venous hyperemia of those pachymeningeal structures and is seen in a large majority of SIH patients, usually around 3/4 of patients, particularly at presentation. So let's summarize those main findings of SIH. You get smooth, diffuse dural thickening and enhancement, so a contrast examination is essential. That finding can diminish over time, and sometimes you can see it on the FLAIR sequence, but FLAIR thickening can be difficult to distinguish from adjacent subdural fluid. The subdural collections can have a range of appearances from thin, smooth hygromas to large bilateral subdural hematomas. And be careful, particularly in those patients with the apparently spontaneous large bilateral subdural hematomas. You as the radiologist may be the only person who looks for the ancillary findings of SIH. Those patients do not need burr hole drainage. They need management of their underlying SIH. Now, as I said, we can see venous distension at a number of points, that inferior border of the midpoint of the transverse sinus being downwardly convex. You can also see it on the axial imaging. So the posterior aspect of the superior sagittal sinus should normally look biconcave, and it becomes abnormally rounded. Here it is just after it's divided at the torcula, being abnormally rounded. And here we can see the straight sinus appears abnormally distended. Now, this venous distension sign is one of the first signs to disappear after successful treatment of SIH. Now, to show you brain sag compared to normal, normally we should see a nice convex superior profile of the midbrain. Here we can see it appears indistinct and it looks flattened. Here it looks even dorsally displaced. And if we draw a line, an imaginary line along the optic chiasm and the floor of the third ventricle, you can see that that should normally be upward sloping. In SIH, that line becomes flattened and may even be downsloping. If we draw a line from the mammillary body to the pons, this is known as the mamillopontine distance. That distance becomes narrowed in SIH as we get that brainstem anatomical distortion, drooping of the mammillary body closer to the pons. And as a result of that, the pons also itself becomes distorted. So normally it should be nice, have a nice convex belly with clear prepontine CSF. Here you can see that ventral surface of the pons is flattened with narrowing of that prepontine cistern. And here again, flattening of that ventral surface of the pons and cerebellar tonsillar descent. And as I said, you can see evidence of the brain sag on the axial imaging. That normal interpeduncular cistern and angle becomes narrowed and the conspicuity of the CSF becomes reduced there. Now remember that venous hyperemia of the pituitary gland can mimic or be mistaken for an adenoma or a hypophysitis. And sometimes we do see these come to our pituitary MDT meetings. And the key here is to look for the ancillary signs of SIH. So here we can see that narrowing of that mammillapontine distance, the flattening of the ventral surface of the pons, the narrowing of the prepontine cistern, the cerebellar tonsillar descent. Here we can see that dural thickening and enhancement running along the clivus, the posterior fossa into the spine even, and you can see here the venous sinus distension. Now, those findings that I've described, those key findings of SIH may be present to varying degrees, especially in chronic leak patients. There are a few other clues we can look for. We can look at the optic nerve sheath subarachnoid space. So in normal patients, you should see some perioptic CSF signal. In SIH, that space becomes collapsed, conversely compared to IIH, where it's distended. And a more recently described finding, particularly in patients with a chronic leak or chronic symptoms, is that of a diffuse calvarial hyperostosis. And in most of those cases, you see this concentric or layered appearance to the skull with a layer of hyperostotic bone deep to the inner table, known as the layer cake skull. And this is in contrast to, say, the appearance of a hyperostosis, which has a more localized and irregular knobbly appearance. Now, there are a few situations in which we need to be careful. Look at both of these images. They both have evidence of cerebellar tonsillar descent, but these are not the same, and looking for the additional signs of SIH will help you and save you from mislabeling it as a Chiari. So here we can see that superior convexity of the pituitary gland. Look at the midbrain. We can't see it. Normal anatomy looks indistinct. It's been squashed downwards. Look at the pons. The ventral surface appears flattened. We've got narrowing of the prepontine cistern, and we can see here evidence of venous sinus distension. Compare it to here where in fact we've got intracellular arachnoid herniation. If we draw that normal line along the floor of the third ventricle from the optic chiasm, it's normally upward sloping. There's no venous sinus distension or evidence of brainstem sag. This is a Chiari and this is SIH. And making that distinction will prevent this from happening. So this was a patient who presented with headaches. The neurosurgeons did not get their radiologist to review the case, and they went ahead and did a foramen magnum decompression thinking it was a Chiari malformation. Now they're coming back to say the patient is still symptomatic. Why? Well, the post-operative imaging shows the same as the preoperative imaging. The pituitary gland convexity, hyperemia. The brainstem looks as though it's been distorted, that midbrain sagging backwards. The floor of the third ventricle is downsloping, the venous sinus distension. This patient has SIH and they need management of that. Now, we've talked about how brain MRI may show all or only some of the typical findings to varying degrees. But it's actually reported to be normal in up to 20% of patients later proven to have a leak, but with a good clinical history. And it's more often normal in patients with a longer duration of symptoms, which leads to further delay in diagnosis. So if the history is good, go back and look for those imaging clues again, particularly on the initial imaging. Now that you've made the diagnosis of SIH, you might think about conservative or non-targeted management options, and then if those fail, you can think about finding the cause. And if we wish to localize a leak point, then we need to image the spine, and we begin with an MRI spine and then think about myelography. Let's talk about each of these complementary methods, both of which are necessary to localize leaks. So we usually perform a spine MRI at the same time that we perform imaging of the brain. And the reason for the spine MRI is to help stratify the type of leak, i.e. is it a fast or a slow leak? And that is determined by the presence of a SLEC or not. And this helps direct us to the etiology of the leak and therefore direct an appropriate myelographic strategy to find it. So here we have sagittal T2 imaging, and what we can see is evidence of extradural CSF outside of the hypointense line of the dura. So you can see CSF behind it in the subarachnoid space, and then in front of it here we have evidence of a ventral SLEC. When we come further down the spine, you can also see evidence of dorsal fluid as well. How do we know that's not epidural fat? Well, what we can see when we look at the T1 imaging is that this has fluid signal characteristics. Now, when we look at the axial imaging, and we like to do some form of 3D T2 imaging because it provides us with really nice anatomical definition and can pick up even shallow SLECs, so really subtle SLECs. Here we've got quite a clearly defined example. Here's that hypointense line of the dura with fluid layering anteriorly to it within the ventral epidural space. As we come further down the spine, you can see that there's fluid layering dorsally as well, and it becomes circumferential as we head further into the thoracic spine, and this is a large SLEC that extends into the lumbar spine. So large circumferential SLEC. So when you see a SLEC, it indicates that there is a fast leak or a dural tear of some kind. And the location of the SLEC can be helpful. So here we see evidence of a ventral SLEC. Here it's predominantly ventral, anterior to that hypointense line. Here you can see there's a sliver of dorsal fluid as well. And when we see a ventral SLEC, we're thinking this is likely to be a ventral dural tear. So therefore most likely to be from a discogenic spur. So be on the lookout for that on your MRI as well, especially if you see an isolated little discal spur. But remember, it's not always the largest disc. If you're seeing more circumferential or dorsal fluid, it could still be a ventral tear because these patients are often lying dependently, or it could be due to a lateral fast leak, so a nerve root sleeve tear, or say a fast leaking diverticulum. Now, why is knowing whether a leak is leaking fast or not important? Because it helps to choose the right myelogram. With fast leaks, you're going to want some form of dynamic imaging, which has a high temporal resolution, as the leaks are quite literally leaking fast. Now, as a little bit of an aside, if you see a SLEC, make sure you check for this, infratentorial superficial siderosis. Now, here are some gradient echo images. You can also see these on susceptibility weighted imaging, or if you're lucky, even a standard T2. And what we see is this dark T2 style hypointensity pertaining to the infratentorial peel surfaces. And this is thought to be associated with friable blood vessels at the margins of spinal dural defects, which bleed chronically over time and lead to hemosiderin deposition on those cerebellar peel surfaces and also along the spinal cord. So we should look for superficial siderosis in SIH cases, and also conversely consider a dural tear and a leak in patients who have the classic infratentorial superficial siderosis, which may present very differently, for example with ataxia and hearing loss, and they may not have the classic brain MRI findings of SIH or even any clinical symptoms of SIH. And that's important because if we want to halt the progression of siderosis to prevent clinical deterioration, then that would mean finding and treating the spinal dural defect. Now, we've talked about how the primary role of spinal MRI is to detect a SLEC. Unfortunately, the extent of the SLEC doesn't tell us where the exact site of the leak is, but it may give us a clue to the leak site. For example, be on the lookout for those little discal spurs that I said. Look, for example, if there are any evidence of diverticular, if they appear irregular. And if you're really lucky, you may even see the site of the dural defect. So here we can see this patient has a large, predominantly ventral SLEC. You can see that just anterior to the hypointense line of the dura. There's also a little bit of dorsal fluid there as well. And look, just on the edge of this image, you can see that there's T2 hypointensity pertaining to that cerebellar vermis and those cerebellar peel surfaces. So this patient has siderosis, indicative that these SLECs and therefore the dural tear has probably been there for some time. Now, when we look at the 3D T2 imaging, we can really make out a lot of anatomical detail. So that's the utility of performing 3D T2. You can see that the SLEC is mainly ventral, but also in the right lateral location. And what we can see here, as we come to this C5, C6 level, is a discrete defect in the dura at this level. And as we go further down, we can see another further discrete dural defect. And we can also see absence of the nerve roots extending into the neuroforamina at these levels. And this was consistent with a preganglionic brachial plexus injury, and the patient subsequently disclosed a history of a motorcycle accident some years previously. Now remember these broad groupings of leak, let's have a look at how we find them. And if we want to properly localize, that requires myelography. And this would be perhaps when conservative management measures and perhaps epidural blood patches have been tried and not been successful. It's really important that you choose the right myelographic technique for the leak etiology under suspicion. Otherwise, you may not be successful in locating the leak. Now, there's been a lot of progress made in advances in myelographic techniques in the last 10 years, and that has also led to our advances in our understanding of causes of leaks based on that, which has led to further iterative refinements in myelography. Now, there are multiple techniques with no one right way to locate a leak, but these can broadly be divided into CT-based techniques, fluoroscopic techniques, and MR-GAD myelography. I'm not going to say much about this latter technique, other than to say it may have some utility as a third-line test, say when the CT-based and fluoroscopic measures have been tried and perhaps not really located a source of leak. So perhaps when you're suspecting a slow leak or an intermittent leak, perhaps a slowly leaking CSF venous fistula or diverticulum. But remember that installation of intrathecal gadolinium is still an off-license indication, and you would have to counsel the patient as such. So I'm going to discuss the types that I find the most useful. So I'm going to start with the on-table flat CT myelogram. This is where we do a lumbar puncture under CT guidance and instill iodinated contrast. We then ask the patient to lift their pelvis to encourage the cranial flow of contrast, and then roll through at least 360 degrees to ensure an even coating of the thoracic and cervical subarachnoid space. And then we image as quickly as possible under a breath hold using a small field of view and as thin cut high resolution as possible. So here is an example. You can see contrast opacifying throughout the thoracic subarachnoid space. You can see that it's opacifying some little diverticular laterally as well. And what you can see on the right side, which is abnormal, is all these little irregular squiggles, which are opacifying with contrast around that diverticulum. A little curvilinear structure extending anteriorly here, and then some other little squiggles that are opacifying. And generally there's a haze of opacification around this region. And this is all part of the meshwork of a CSF venous fistula that was at the right T10 level. But I actually find that a better method if you're thinking about a CSF venous fistula or a lateral leak is to do lateral decubitus CT myelography. And that's essentially the same technique, but this time it's performed with the patient lying on one side. So you may need to do consecutive sides on consecutive days or the same day. So this is really good for when we're suspecting those lateral leaks. So here you can see I've done the lumbar puncture at L2-3, and you can see that the patient is lying on their right-hand side. They're on a wedge to encourage that cranial flow of contrast, and you can see here that there is contrast dependently layering on the right-hand side. Now, we tend to scan the whole spine and carefully scrutinize each level for evidence of a CSF venous fistula. So here you can see that there's dependent layering of contrast, mostly on the right side, opacifying that diverticulum. So you get a really good contrast density, and that can make picking up those CSF venous fistulas a little bit easier. And what you can see here is these little abnormal squiggles around that diverticulum is those abnormal radicular veins, that abnormal venous meshwork of the CSF venous fistula, which is opacifying with contrast around that diverticulum. And what we can also see is an anterior draining vein that is opacifying with contrast, passing anteriorly around the lateral aspect of that vertebral body and heading towards the azygos system. So this was a CSF venous fistula at the right T5 level. We can also clearly see that hyperdense paraspinal draining vein on those sagittal images coursing around that lateral aspect of the vertebral body, and on the coronal images you can see those abnormal little radicular veins, that venous meshwork around that diverticulum. Now here's an example of another case. Now this patient had a history of headaches for 4 years and was told her imaging was normal. So she was dismissed as having migraines, but actually her imaging is not normal. She was a young patient and her skull looks diffusely hyperostotic, and it looks abnormal in its composition also. Remember that layer cake finding we described, that inner layer of hyperostotic bone that sometimes we see in patients with chronic leak. She has that. And the more we look, the more we see. Here you can see that her interpeduncular cistern has been narrowed. On the contrast imaging, she doesn't have much in the way of pachymeningeal enhancement or thickening, but remember I said that finding may diminish in patients with chronic leak. And on the sagittal imaging, it's all there. You can see the pituitary gland looks enlarged. She has venous sinus distension. And look at the brainstem. It's showing evidence of brainstem sag. So we did an MRI spine and we couldn't see a SLEC, so we were suspicious of a CSF venous fistula, so we went straight for lateral decubitus CTM. And you can see here the layering of contrast on the left side. And what you can see here is that it is in fact pacifying a little diverticulum on this left side at the T5 level, but there are all these little abnormal little squiggles that are arising anteriorly around that diverticulum. And look where they head. They head into that anterior epidural space, so suggestive they're in the anterior epidural venous plexus. And then you can see this little anterior epidural vein, which then enters the vertebral body, traverses across it, and then exits around the right lateral aspect of that vertebral body, and then drains via this draining right-sided paraspinal vein, which then drains into the azygos vein. So here what we have is a CSF venous fistula on the left side, which is draining via that anterior epidural venous plexus transosseously onto a right-sided draining paraspinal vein. Now, an important finding that we should look for if we haven't seen anything is one of early renal excretion of contrast. So here we can see that there's renal pelvis accumulation of contrast, which has occurred within really only a few minutes of injecting the contrast. And that's an abnormal finding. You shouldn't normally see this early renal excretion with myelograms done for other causes. So if you haven't seen your CSF venous fistula, but you have that finding, then go back and carefully scrutinize every image and look for that CSF venous fistula. Now let's have a look at a dynamic CT method for localizing fast leaks. And these are in patients in whom we've seen SLEC, so epidural fluid. And for that we do an ultra-fast dynamic CT myelogram. We position the patient for where we think the leak is going to be. So if there's ventral SLEC, we're thinking about a ventral dural tear, we'll put the patient prone because we want to encourage the contrast to come out of the hole where it's leaking from. They're on a wedge to get that cranial flow of contrast. And what we do is we do the lumbar puncture and inject contrast and start scanning right away up and down the spine. You can do up to 6 runs craniocaudal, but we usually find that the leak is evident by run 3, and clearly if you do 6 runs, that's a big radiation dose. We often start off with a non-contrast scan to look for those tiny little calcified bony spicules. Now the reason we can't scan with a delay is that by 60 seconds, any fast leak where there is a collection will have already opacified with contrast, and it may obscure the direct point of leak. We want to be able to see contrast pouring out of the hole in the dura. So with those progressive runs, you can see that progressive extension of that contrast column up the spine. So here we can see the axial images from the third run of a prone ultrafast dynamic CT myelogram, and you can see contrast layering dependently on that ventral inner surface of the dura in the thoracic spine. Now, as we come further up, we're beginning to see some irregularity within that anterior epidural space. And here you can see a little calcified discal spur that is projecting dorsally into the vertebral canal at that level. And just beyond that, you then see a little area just off midline where contrast is directly exiting the theca at that point and heading into that ventral SLEC. Now, the sagittal reformats of the same data show this split or this fork in the contrast column, which occurs at the level of that calcified disc spur at T4, T5. So you can be really clear about the level that that leak is occurring. Here is another patient, a different patient to the one that we've just seen, where you can see a bony spicule on that non-contrast run at the T12L1 disc space. On this third run, what we can see is again that similar fork in the contrast column with contrast leaking out at the level of that disc. But can you see how it's pretty difficult to see the spicule at that level once you've given contrast? So it can be important to do a non-contrast run first. You can also use ultra-fast dynamic CTM to look for nerve root sleeve leak. So here we've got progressive runs, run 1, 2, 3, 4 from an ultra-fast. And what we can see on consecutive passes is that there's contrast accumulating in that right T11, T12 neural foramen. And what we can see here on the axial images is extensive opacification of a circumferential epidural collection outside of the dura in the thoracic spine. But importantly, there's a gradient to the contrast density. Can you see how it's slightly worse here within that right T11, T12 region? And you get the impression of a lobulated, partially contained collection of contrast in this location. And on the coronal images, that becomes even more evident as you see that bilobe structure surrounding that T11 nerve root, consistent with a large complex pseudodiverticulum. And at surgery, this was found to be a partially contained ruptured nerve root sleeve. Now let's have a look at some fluoroscopic techniques. Now these are dynamic in that they watch where a contrast bolus is traveling in real time and therefore hopefully into a leak point. So you can do dynamic fluoroscopic myelography, which can be done on any fluoro table that has bone overlay. So sometimes it can be difficult to see those subtle leak points unless you're an experienced operator. One of the main workhorses for leak localization successfully is digital subtraction myelography. And this has the advantage that it subtracts the bone and therefore has a really high spatial resolution. Now these are essentially fluoroscopic images that are taken on an angio table that can tilt, and it has the advantage that it has really high temporal resolution with that rapid image acquisition of a run, but also a high spatial resolution. Now first you position the patient depending on where you think the leak is. So I'd position them prone for patients with ventral slex and therefore thinking about a ventral tear, and then lateral decubitus for any kind of lateral leak such as a CSF venous fistula or diverticulum, and therefore you may have to do both sides. You do the lumbar puncture under fluoro, tilt the table, and then inject the contrast under a breath hold to limit motion, and then perform a rapid image acquisition. So here is an example of a lateral projection of a prone DSM. So this was where we were suspecting a ventral leak because they had a ventral SLEC. And what we can see here is that contrast is running cranially within the thoracic subarachnoid space before rapidly leaking at the T4, T5 disc level into a ventral epidural fluid collection. And what we can see here is the direct point at which contrast is passing out into that SLEC, the similar appearance of that fork or split in the contrast column. So again, you can be really clear about the level that that's occurring. Here we can just about see the bony images. We use this ball bearing to help us with counting the vertebral levels. Now here is an example of a patient who's having decubitus DSM, so we were suspecting a CSF venous fistula. Here they're layering on their right side, so you can see dependent layering on the right. And what you can see is progressive opacification of this little diverticulum at the T10 level. But what is going on around it? You can see all these little irregular squiggles that are opacifying with contrast. And these are these abnormal little venous meshwork that forms part of a CSF venous fistula at this right T10 level. And right towards the end of the run, you can just about see that there is this flickering of this paraspinal vein that just comes into view. And sometimes we need to do these sort of magged up images to really look for those findings. And it was really only towards the end of that breath hold that we could see the flickering of that paraspinal vein coming into view. But all of this venous meshwork is suggestive of a CSF venous fistula. Now let's move on to management, and this can be divided into non-targeted and targeted. And targeted requires the leak localization methods we've just described. But often after MRI diagnosis of SIH, we can start with simple, often successful methods. So we can advise the patients to have bed rest, oral caffeine. Caffeine supposedly increases CSF production, keep them well hydrated. Abdominal binders may have an effect. These are effective in really a minority of patients. They're pretty slow to work. They're pretty limiting. A good first-line successful approach in a decent proportion of patients is to do a non-targeted blood patch with or without imaging guidance. Now, we can't be clear on the exact mechanism of action, but it's likely to be a combination of factors. Could be the mass effect of blood in the epidural space causing the cranial shift of CSF and bolstering the intracranial pressure. It may even directly seal a leak site. So here's an example of one we've done under CT guidance. We use CT to help us localize the dorsal epidural space, check the position with a bit of air or contrast injection, as in this case, and then we inject blood mixed with a bit of contrast, and here we can see the deformation of the theca. And we aim to inject as large volume as possible as the patient will tolerate, because the evidence that's out there suggests the larger the volume, and multi-level or two-level is more effective in curing these patients. So success rates vary in total, but around 50 to 60% of patients will respond to at least 2 epidural blood patches. And if that then fails, then you want to be thinking about targeted treatment. And treating the direct leak site, so targeted treatment, requires leak localization methods, and that is from those myelographic strategies we discussed. And the radiologist has a role in management of several of these, mainly in image-guided patching. And this has the advantage that it's minimally invasive, they're day case procedures that are done under local anesthetic, and they generally have a low risk profile compared with open spinal surgery. So I tend to perform our targeted patching under CT guidance. So here's an example of one that I've done for a CSF venous fistula at the T12 level, done a needle localization under CT guidance in this region and injected some fibrin glue mixed with contrast, and the patient was cured of their headaches. Now, the success rates for glue injection are around 30 to 50%, has mixed results for CSF venous fistulas, with more evidence coming out in the last year. And there are better outcomes reported if the sealant is seen to pacify the draining veins. It can require more than one treatment session. You can also do transforaminal placement, for example, here in this case for a leaking diverticulum where we've injected glue and a bit of contrast, and also for those ventral dural tears. Here was targeted patching of a ventral leak with the needle in the anterior epidural space with spread of contrast, a pacified glue across the midline. Now, a treatment that's been described only this year is one of endovascular treatment for CSF venous fistulas by the Mayo Clinic group. And this is really exciting because what they've done is they've catheterized subsegmental draining veins that drain those CSF venous fistulas, and then they inject a liquid embolic agent. Here was one of a bilateral CSF venous fistula, and they've reported really great results from their series. But sometimes we do have to call in the surgeons, and there is a variety of surgical approaches depending on the underlying leak type. So, for example, directly suturing a dural tear, clipping or tying off of a cyst or draining vein, or even a nerve root ligation, which will sacrifice the nerve root. Now, remember this case, this 47-year-old woman who presented with this rapidly progressive dementia. Now, this was one of the first SIH cases I ever investigated, and whilst it is a rare presentation, it is known, and it was a tricky one. So when we look back at the imaging findings, they're all there. You can see that brainstem anatomical distortion, that narrowed interpeduncular cistern. You can see that she does have thin, smooth dural thickening and enhancement. And you can see here that she has clear evidence of brain sag. Her MRI did not show a SLEC, so we were thinking about, has she got a leaking diverticulum, particularly because she did have some irregular diverticular or even a CSF venous fistula. We tried a couple of epidural blood patches which were non-targeted, but they had minimal response. And so we went on to do digital subtraction myelography under general anesthetic. And what we saw was this irregular diverticulum at the C6 level with evidence of extra diverticular contrast leakage. And on the CT myelogram, you can see here these little squiggles that are opacifying with contrast around that diverticulum. So I did a fibrin glue injection. Here you can see located extra diverticular around that diverticulum, and she made a cognitive improvement which was pretty successful for around a week, and then she deteriorated again. So eventually she had to go for tying off of that large diverticulum, and that cured her. So she had a really long inpatient journey, and you can see the critical case, or from this critical case, the pivotal role of the radiologist in making the diagnosis, the initial management, investigating her leak, further treatment. And she had such a long admission, but we eventually got there, and the outcome was cure. And we are nearly at the end of our own CSF leak journey. Now, there's a great variety in institutional approaches to investigation and management, and there's no one correct way. It depends on the local expertise and your resources. But this is the pathway I would follow. If you have a clinical suspicion of SIH, do brain and whole spine imaging and give contrast. If it confirms SIH, consider up to 2 non-targeted blood patches. If they have persistent symptoms, which they will in roughly half of cases, does the patient have a SLEC on their spine? If they do, you're thinking about a fast leak. Where is that SLEC located? If it's ventral, you're thinking about a ventral dural tear, so do some form of prone dynamic imaging, such as an ultra-fast dynamic CTM or a DSM. If it's circumferential, you could think about decubitus myelography using those methods. If you locate the leak, why not start with targeted patching because it's minimally invasive, but you may have to progress to surgery. If you haven't located it, consider repeating it. Now, if there's no SLEC, but good imaging evidence of SIH, you're thinking about a CSF venous fistula, in which case, go straight for some form of decubitus myelography. Now, always also consider those patients who have a good clinical history but are imaging negative, how they might feed into this pathway. There's no one right way. You might think about doing a diagnostic blood patch to think about if there's a pressure response, and therefore you're suspecting maybe an intermittent or slow leaking CSF venous fistula, and they may need to progress to decubitus myelography. So in conclusion, we have learned that SIH is a curable condition that is caused by a spinal CSF leak. CSF leak points can be better characterized with better neuroimaging techniques, and neuroradiology-guided targeted patching can definitively treat and may avoid the need for open surgery. I hope you enjoyed this talk. Thanks for listening.